Hello, my name is Dr. Nicola Cooper. I'm a consultant in internal medicine at Royal Derby Hospital, also a clinical associate professor in medical education. My particular interest is in clinical thinking and decision making, and so I've been asked to run this session for you as part of your clinical management investigations and referral module. This session is probably going to take a couple of hours, so get ready to hit the pause button every so often. Get yourself a notepad and pen to jot down learning areas for yourself that you need to go and explore in more detail later. So the learning outcomes for this particular session, which link in with your module's learning outcomes around assessment, interpretation of investigations, clinical decision making and communication. By the end of this session, you'll be able to know what's meant by clinical reasoning, why it matters, and how it develops in individuals. Know the components of clinical reasoning and have an idea of the specific knowledge, skills and behaviours that are required in each of these components to be safe and sound. And also have an understanding of how to reduce errors in clinical reasoning in your own practice, and also how to continue to learn and to get good. Now, I do strongly recommend that you all read at a very minimum Chapter 1 in Davidson's Principles and Practice of Medicine. Davidson's Principles and Practice of Medicine is a standard core textbook for medical students. The other one is called Kumar and Clark Medicine. You should have, as a trainee ACP, one of these books if you're going to be doing any medical stuff and not purely surgery or paediatrics, for example. I also recommend you read the book called The ABC of Clinical Reasoning. If you don't want to read the whole thing, which I do recommend, then you definitely need to read Chapter 3, which is all about using and interpreting diagnostic tests. Evidence-based physical diagnosis, we'll touch on that in a bit. I recommend it, but I also do recommend a book called Medical Terminology for Dummies, and you'll see why I've recommended that book. It's because precise medical language is very important, not only in communicating with other clinicians, but in helping us to organise our knowledge and retrieve our learning from long-term memory when we're trying to sum up what's going on with a particular case. I've provided an A4 quick introduction to medical terminology for dummies, which should be on your virtual learning platform. 3 websites I recommend here. Internalmedicineteaching.org has a range of resources for learning topics in internal medicine. Just go to the resources page. Okay, so basically, clinical decision making describes the thinking and decision making processes associated with clinical practice. More commonly, it's called clinical reasoning, and there's a vast clinical reasoning literature in medical education, not just medical education, but in the other health professions as well. But it's been a particular topic of research in the med-ed literature, especially in the last 10 to 15 years. So what we're going to do in this session is we're just going to introduce clinical reasoning, including why does it matter, and a bit about how it develops in individuals, because this is quite key. Then we're going to go into the nuts and bolts of things, and I'm going to explain a good way to conceptualise clinical reasoning in terms of the different components. And we're going to look at these different components, but through a clinical reasoning lens. In other words, what are the specific knowledge, skills and behaviours that you need to be able to make good decisions? And finally, we'll touch on ways to reduce errors in clinical reasoning in your own practice in the future. So this is a recap of what we're going to cover. So let's start with What is clinical reasoning? So there are lots of different definitions, but the easiest one to think of is this. You can conceptualize clinical reasoning as a process with different components, and each component requires specific knowledge, skills, and behaviours. And these are the four major components: history and physical exam, choosing and interpreting diagnostic tests, problem identification and management, and finally shared decision making. There's a lot more to it than that, and we're going to explore it in more detail. Now, of course, not all of these components are necessary for effective clinical reasoning. They don't necessarily happen in this order. They can occur, within seconds or within weeks over many consultations. And of course, they occur in context. Clinical reasoning is situated in context that has a powerful impact on our decision making, often in ways we don't realise, and this is explored further in the sections on cognitive biases and also human factors. Now, a common misperception is that clinical reasoning is the same as critical thinking. This is absolutely not correct. Clinical reasoning, history, physical exam, etc., involves the senses: vision, hearing, touch, smell, communication skills, rapport, knowledge of epidemiology, basic sciences, and clinical medicine. It's not the same as critical thinking, although this is one aspect of clinical reasoning, particularly when we get to the problem identification aspect of it, but they're not the same thing. So back to our framework for thinking about clinical reasoning. It is important to state very clearly that underpinning all of this process and these different components is formal and experiential knowledge of basic sciences, epidemiology, and clinical medicine. It is a fact that you cannot reason, think, and make decisions without knowledge. And so we'll start by asking the question, when I say knowledge, what do I mean by knowledge? So here's an arterial blood gas result. And to be able to understand what this even means, you need factual knowledge. You need to know what pH means. What is the partial pressure of CO2 and the partial pressure of oxygen? What does that mean? You also need to have conceptual knowledge. That's how all these different things fit together. An understanding of physiology, a model for understanding blood gases. You need procedural knowledge, how to go about something, how to read a blood gas, when to take a blood gas sample. And you also need metacognitive knowledge. That's a higher level of knowledge. So I'm looking at this blood gas result, and the first thing that I thought was, this is bad. But we'll touch on this later. You need to have strategic and self-knowledge. You need to be aware of what you know and what you don't know, and that's called metacognitive knowledge. I need to read up on that. These different types of knowledge dimensions are summarised in this diagram here. And the reason why I'm starting with this is because all the evidence to date points to the fact that sound clinical decision making is highly dependent on formal and experiential knowledge of medicine. So once again, that's epidemiology, that's what kind of patients get what kind of diseases, basic sciences, and clinical medicine. And if you want to step into the role that's traditionally been taken by doctors, i.e. you are going to start seeing undifferentiated acute medical problems, but without 5 years at university full-time, followed by 5 to 10 years as an apprentice before being allowed to practice independently, then you certainly have to be prepared to put in the study that is required. You need to read proper material, and you need to make sure that you are always aware of the limitations of your knowledge base, and make the most of always discussing cases with experts so you keep on learning. Why does this matter? Well, we know that diagnostic error appears to be the most common, the most costly, and the most dangerous of medical mistakes. Around 10 to 15% of diagnoses are wrong, and that's across all specialties, but particularly in the undifferentiated specialties, that's general practice, emergency medicine, internal medicine. And we know that diagnostic error is more likely to lead to serious harm than other types of error. And this report shown here, Improving Diagnosis in Healthcare, was published in 2016. And among its recommendations are that curricular and training programs should explicitly address performance in the diagnostic process, because to date that hasn't necessarily been the case. And the World Health Organization has identified diagnostic error as an important, a priority patient safety problem. Based on post-mortem studies, undiagnosed disease, which could have been treated in life, is found in 10 to 20% of people after death. And when extrapolated, that's 40 to 80,000 deaths annually in the US, and that's somewhere between breast cancer and diabetes. Chances are we'll all experience a diagnostic error in our lifetime, but as I say, the evidence is pretty clear that diagnostic error is a cause of significant harm. And so people have become very interested, particularly in the last few decades, about why diagnostic error happens and what we can do about it, but particularly not only from a systems point of view, but from a medical education point of view. So why does diagnostic error happen? Now, one definition of diagnostic error is the individual clinician had all the information to make the right diagnosis and then made the wrong diagnosis. And in 2005, this paper was published, and they looked at 100 cases of serious diagnostic error, including 33 deaths across 5 tertiary hospitals in the US, and they looked at the root causes of the diagnostic error in each case. Each case had an average of 6 root causes, reasons why the diagnosis was wrong, and as you can imagine, system factors played a big role. But what they found was that cognitive errors were the most common contributor to diagnostic error. In other words, the doctor had all the information available to make the right diagnosis, but then made the wrong or a delayed diagnosis. And what they stated in this paper was that faulty or inadequate knowledge was uncommon, but things like premature closure, misjudging of the salience of findings, and errors arising from cognitive biases were the common causes of diagnostic error. I'm going to talk about cognitive biases later. They're subconscious errors of judgment that are prevalent in everyday life. And so this idea that the most common reason for diagnostic error was cognitive errors, particularly something called faulty synthesis. This spearheaded a move among medical educators to try and better understand and therefore teach the thinking processes involved in diagnosis. But 10 years later, researchers hit a dead end. And the problem is that to date, there's no evidence that teaching general thinking skills or things like cognitive debiasing strategies leads to any improvement in performance. In fact, a diagnostic error is more likely not to reflect a processing error, but an incomplete knowledge base or inadequate experience. So, is diagnostic error due to a problem with thinking itself or a problem with knowledge and experience? Well, actually, the answer is both. Knowledge and experience is absolutely key to diagnostic accuracy, but also there is something about the way we think which is important, and as we go through, you will see what I mean more clearly. Let's go back in time to the 1970s when researchers first got interested in what made someone good at diagnosis. So, what do we know about clinical reasoning ability and how it develops in individuals? Well, in the 1970s, expertise in medicine was considered to be related to superior general thinking ability. So researchers decided to study this. And they watched medical students and then consultants see simulated patients. They video recorded them and they analysed what was going on. What they found was that there was actually no difference in the process or the thinking strategies used by the experts compared with the students. Both quickly came up with one or more diagnostic hypotheses. This guided the search for further information. But the experts were more accurate because they knew more. The other interesting thing that the researchers found was that success in one problem was a poor predictor of success in another. So the performance of even experienced physicians varied markedly from case to case within their own specialty. And again, we'll talk later about knowledge and how knowledge is organised to be orientated to solve problems. And the researchers concluded, and this was a groundbreaking study at the time, that two of the most important determinants of competence are information and experience. Problem-solving skills without a rich supply of facts are insufficient for diagnostic acumen. And so this led to researchers changing direction and examining the role of knowledge in medical expertise. So researchers asked the question, do experts have bigger, better memories? And the answer to that is no, because given unlimited time, novices can remember as much as experts about a clinical case on paper. But what's interesting, and you may have observed this yourself when you're discussing a case with an expert GP or a consultant, experts appear to acquire information more efficiently. They pay attention to more critical information. Now, the reason there's a chessboard on this slide is because quite a well-known experiment, again in the 70s, took chess grandmasters and novices and showed them chessboards with around 25 pieces on them, set up as if in the middle of a game. And the participants were shown the boards for only 5 seconds and then asked to recall the positions of as many pieces as possible. The chess grandmasters could recall the position of most of the pieces, around 20, but the novice could only remember around 4. But the clever thing about this experiment is that they repeated it. But this time, the pieces were randomly distributed on the board. And guess what happened? This time, the chess grandmasters performed no better than everyone else. Why? Well, years of formal study, experience, and reflection in playing chess means that when a chess grandmaster looks at the pieces on a board as if in the middle of a game, they're seeing a pattern. The pieces are like letters in a word, and that word has meaning, and the whole word is stored in long-term memory as a chunk, not as individual letters or individual chess pieces. When we look at a word, let's imagine the word remember, we just see the whole word, not the individual letters, which is maybe what a 4-year-old learning to read would see. And in medicine, and as well as in other domains, studies show that knowledge is organised differently in the brains of experts as chunks of information, not individual pieces. And we have a name for that. We call it pattern recognition. Experts can overcome the limitations of human working memory by chunking their knowledge. And they can mobilise whole chunks of knowledge from their long-term memory when solving a case as a function of their years of experience. Now, in everyday life, pattern recognition is how we make judgments and decisions most of the time. If I ask you which is the cat and which is the dog, there's no thinking involved at all. But if I was a novice who'd never seen cats or dogs, I would get a bit confused because both of these animals have fur, both have wet noses, both have 4 legs, both have pointy ears, and so on. And then I might fixate on the silver chain around the dog's neck and wonder how significant that is. And eventually the cat might meow, and then I would know that that's the cat. And so novices see these individual pieces and give them equal weight because they haven't yet chunked knowledge in their long-term memories. But over time, they're able to stand back and just say, without thinking, that's the cat and that's the dog. So the human brain has 2 systems that drive problem solving and decision making, and this is decades of research in cognitive psychology, also supported by functional MRI imaging. Humans have an intuitive, pattern recognizing way of thinking and decision making. This is called System 1 or sometimes Type 1 thinking. It's automatic, it's subconscious, it's thinking without thinking. And heuristics means patterns. And we also have a more deliberate, analytical way of thinking and decision making. And this involves effort, it uses working memory, it uses cognitive effort. And the two, and it's not one or the other, they both operate independently, simultaneously, and always. And in everyday life, psychologists reckon we spend around 90% of our time in System 1. So let's take an example. Imagine driving your car. Once you've learned how to drive your car, it becomes automatic. Imagine if you had to drive your car every day as if in your first driving lesson. The cognitive effort involved is too great, and one of the remarkable abilities of the human brain is to be able to relegate things that we've learned to autopilot, to free up cognitive energy. So with a bit of learning and experience, we can start to do things automatically, and that's what experts do all the time. And this is a remarkable property of the human brain. But if you're not an expert, this can lead to problems. So here's an example. Try to solve this puzzle, but don't think about it, just use your intuition. Now, in this experiment, most people say 10p. That's intuitive, it feels right, it's also very wrong. We all have the necessary knowledge to solve this problem. We just probably can't be bothered to get pen and paper out and make an equation. But the human brain is always seeking to conserve cognitive energy. And if you're not an expert, if you just know enough to be able to do things automatically, that's when these mistakes in thinking, pattern recognition gone wrong, or cognitive biases can occur. So the summary of that introduction is that clinical reasoning describes the thinking and decision-making processes in clinical practice. It can be conceptualized as a process with different components that each require specific knowledge, skills, and behaviours. It's situated in context. Context can have a powerful impact on our decision making. It is not the same as critical thinking ability. Now, diagnostic error and this thing called diagnosis education has gained a lot of prominence in the last decade or so. Dual process theory that I've just outlined to you, System 1 and System 2, is widely accepted as a model of clinical reasoning, as a model of how we do diagnosis. Now, that's not all there is to it. It gets more interesting later. All of that was by way of introduction before we move on to the components of clinical reasoning. What I recommend, at this point you may have many questions or thoughts. Just pause this video briefly to jot some things down that you'd like to know the answer to. Hopefully that will be covered as we go along, but otherwise it will form the basis of some of your personal study and research following this presentation. So let's talk about the components of clinical reasoning. So just to recap, clinical reasoning can be conceptualized as a process with different components, and each component requires specific knowledge, skills, and behaviours, which I'm going to go through as we go along. This definition or conceptualisation of clinical reasoning is from the Clinical Reasoning in Med-Ed group. So what we're going to look at first is the history and physical examination, and for all of these components we're going to look at them through a clinical reasoning lens. So we're not going to look at them at a surface level. We're going to look in the detail that helps us make decisions about real patients in clinical practice. So let's start with a case. A 30-year-old woman who presents with gradual onset global severe headache and a fever, let's say 38 degrees C. She comes to your surgery or she presents to ED or the medical assessment unit. What are the features in the history and the physical exam that would make you think she has meningitis and therefore need a lumbar puncture? So just pause the video again to jot down your thoughts. What I want you to do is to list the features in the history, list the features in the physical exam that would make you think that this patient has meningitis. And then what I want you to do is rate each feature on a scale of 1 to 10 in terms of how good it is, in terms of how weighty it is, useful it is in making that decision. Okay, so pause the video and just have a go at that. Now, if you read a standard medical textbook for students, and here's an example from Davidson's, this is what you'll read. So, acute infection of the meninges, in other words, meningitis, presents with a characteristic combination of fever, headache, and meningism. Meningism is headache, photophobia, neck stiffness, and often other signs of meningeal irritation, including Koenig's and Brudinsky's sign. Now, let's imagine you're an ACP about to see this 30-year-old woman with suspected meningitis, and this is maybe what you've read, this is maybe what you've been taught. The problem is it isn't true. So in developed countries that have good access to healthcare and where there are vaccinations against bacterial meningitis, nearly all adults present to hospital or their GP with headache and a fever. But in one lovely prospective study, The next most common symptom in meningitis is nausea and vomiting, and less than half of patients have neck stiffness on examination. We're going to talk about likelihood ratios in a second. And you cannot tell the difference clinically between viral and bacterial meningitis. So basically, how can you possibly make a decision whether or not to perform a lumbar puncture if this is all you know about meningitis? Let's go through some more information. So this is a study that was done in the US, a prospective study. They looked at 300 people who came through the door of the ED with possible meningitis, who went on to have a lumbar puncture. And these were adults, viral, bacterial meningitis, maybe some people were immunosuppressed. As you can see, these are the presenting symptoms. If you look closely, it's not much difference. In terms of the signs on physical examination and the baseline characteristics, i.e. age and gender, and clinical presentation was similar in both groups, but you can see here neck stiffness as a physical examination finding in about a third. And these Koenigs and Brudzinski signs only in 5% of patients. So the main message here is that in today's clinical practice, meningitis commonly occurs without neck stiffness as a physical exam finding. And if you were an infectious diseases consultant or a neurology consultant, you would know that. But this is something, unfortunately, that many medical registrars don't know, for example. And you can see here that neck stiffness and Koenigs and Brudzinski, they're equally likely to be found in people without meningitis and with meningitis. And that's what likelihood ratios are. A likelihood ratio is a diagnostic weight. It's the probability of the finding in patients with the disease over the probability of the finding in patients without the disease. So if the likelihood ratio is around 1, that means it has no weight whatsoever in helping you make a decision. Now, likelihood ratios are clinical diagnostic weights. A likelihood ratio of greater than 1 increases the probability of disease. The higher the value, the greater the probability. An LR of less than 1 decreases the probability of disease. And likelihood ratios are developed against diagnostic standards, for example, lumbar puncture results in the case of meningitis, chest x-ray results in the case of pneumonia. So they don't exist for everything, but they do exist for many things. And likelihood ratios illustrate how an individual clinical finding changes the probability of a disease. So, in a person presenting with headache and fever, global severe headache, high fever, and nothing else to explain it, no tonsillitis, no pyelonephritis, no obvious strep throat or whatever. In this person, the clinical finding of neck stiffness carries little weight in deciding whether to perform a lumbar puncture because likelihood ratios don't determine the prior probability of disease. They only reflect how a single clinical finding changes it. So a clinician has to take all the available information from the history and the physical exam into account. And if the overall clinical probability is high to begin with, whether you have neck stiffness or not, Koenigs or Brudzinski's or not, doesn't change that fact. Let me think of an extreme example. Let's imagine you've got an immunosuppressed patient who's known to have a chronic CSF leak and has had recurrent bacterial meningitis in the past. And this person presents with a gradual onset headache and a fever but when you examine them, there is no neck stiffness and there's no photophobia. But there's nothing else to explain their headache and fever. The starting probability is so high in that patient that a finding with a likelihood ratio of 1 does not change that fact at all. Now, this is called evidence-based history and physical exam, which I'll talk about in a second. Textbooks teach prototypal presentations of diseases, classic, memorable, barn door, when people present late, not how patients present in current everyday clinical practice. And there was a nice article in a journal recently about the perils of teaching medical triads. Medical triads are these 3 things that people get, for example, headache, fever, meningism, because studies show that in fact the majority of patients don't have the 3 things in a triad. So just learning medical triads encourages superficial pattern recognition that results in overconfidence and premature closure. Now, in one lovely study, Ellison and Papa taught students, they taught one group of students just lists of features. These are the symptoms of meningitis. And then they taught another group the probabilities of the features. So, for example, nearly everyone has headache and fever, 70% have nausea and vomiting, half have a symptom of photophobia or neck stiffness, blah, blah, blah. And the students who learned the probabilities were better at diagnosis. But sometimes probabilities are hard to remember, and of course they'll be different depending on what country you're practicing in and on the age of the patient, the type of patient. So in another study they used the same materials, this time the first group learning the probabilities that you'd find certain features, and group 2 learned the basic science explanation of the features. And the group that learned the basic science mechanisms were better when tested later. So in countries where people present early, where viral meningitis is more common, neck stiffness will be present in people who have severe inflammation. And in that study I showed you, it was when they had more than 1,000 white cells in their CSF. Mild meningeal inflammation does not lead to neck stiffness. And if you understand that, then this makes sense. So this is called evidence-based history and physical examination. It's absolutely vital to understand these more than superficial novice facts about clinical presentations, because we still, with the explosion of technology in the last 30 years, we still make a diagnosis on the basis of the history and the physical examination. The history and the physical examination combined are powerful, but of course it requires knowledge to be able to synthesize the facts from the history and physical exam to make a judgment called the pre-test probability of disease. So that's a judgment based on your knowledge of epidemiology, basic science, clinical medicine, a judgment of whether this is unlikely or likely that a patient has a particular disease. And the reason that I've emphasised this is because the pre-test probability is absolutely essential when it comes to using and interpreting diagnostic tests. Just take a moment now to pause, jot down your thoughts. I've used one example of suspected meningitis in an adult. There are many examples about how diseases present. How does cardiac chest pain present? What would you do if someone had lower central chest pain but associated with a lot of belching? Do you know that belching is associated with acute coronary syndromes, or would you put that down to simply indigestion, despite the fact that this might be a male smoker with diabetes? I'm going to talk a bit more about this as we go along, but I hope you see that how important this idea of evidence-based history in exam is, and it's clearly something that you can't learn in a hurry. It's going to take years to acquire this kind of knowledge and experience, and also effort, formal study, as well as working within a team alongside experts. Okay, so hopefully you've paused to jot down some questions, some thoughts, some learning areas for yourself. And the reason I really emphasised the importance of the history in the physical exam is because that is absolutely fundamental to making clinical decisions. And medical students, for example, will spend 5 years learning how to take a history and do a physical exam, and then when they graduate they'll learn it all over again before doing higher exams such as the MRCP. So let's go on to choosing and interpreting tests. Studies have shown that many qualified health professionals lack the knowledge and understanding in areas that are fundamental to the diagnostic process, like how to interpret test results. In this systematic review of 13 studies, clinicians were provided data on the clinical probability and then the sensitivity and specificity of the test, and were asked to judge the actual probability that a patient had a disease, and the results were quite poor, ranging from 0 to 61% correct, but a lot of participants who didn't respond to questions up to 40%. So let's start with a case. Imagine a 60-year-old smoker who presents with persistent breathlessness on exertion and wheeze. What's the probability of him having emphysema if he has a normal spirometry result? And let's imagine when you see him he has a hyperexpanded chest, and based on the history and the physical exam you think 90% this man has got obstructive pulmonary disease. So just pause to jot down your thoughts, and the answer will be revealed as we go along. So before we explore the answer to that question, tests lie. Tests give us test probabilities, not real probabilities. Because all test results are affected by the following things. First, how we define normal, which is a statistical construct that I'll explain in a minute. There are factors other than disease which influence test results. There's something called the operating characteristics of a test that are important to understand. That's how the test is actually performed. There's something very important called sensitivity and specificity, which we'll explore in more detail. And finally, the prevalence of disease in the population impacts on how we interpret a test result as well. So let's start with normal values. Most test results have a normal distribution. That's a Gaussian distribution, this curve that you see here. And to define what's healthy or unhealthy, what's normal and what's diseased, we have to have a cut-off point. And traditionally, by convention, the normal range is defined as those values that encompass 95% of the healthy population, or 2 standard deviations above and below the mean. So what that means is that 2.5% of normal people have values above the reference range, and 2.5% of people have values below. So that's why we talk about the reference range as opposed to the normal range, because you can be normal and outside the reference range. Now, test results in abnormal populations, those with disease, they also have this Gaussian or normal distribution, but they have different means and different standard deviations. And in some diseases there's no overlap at all, but in others there is. And when there is, the greater the difference between the test result and the limits of the reference range, the higher the chance the person has a disease. However, there are some situations in medicine when normal is abnormal and abnormal is normal. So, for example, a normal PaCO2 in the context of a severe asthma attack, that's abnormal, and that means the patient has life-threatening asthma. A low ferritin, i.e. iron deficiency, in a young menstruating woman is considered to be normal and not a disease at all. So normal to some extent is arbitrary. There's also something called the critical difference for lab tests. So things like cholesterol, TSH, HbA1c, if you took that test in the same person every single day and nothing about them had truly changed, the result would be different every day due to natural variation, biological variation, and also due to lab variation. The extent to which a result is allowed to change, is allowed to normally fluctuate before it truly has changed, is called the critical difference. And that is as high as 17% for cholesterol. It's above 50% for TSH. And every result has its own critical difference, which is important to know about, for example, when you're doing routine tests in patients for things like CKD or diabetes, or just following up their thyroid function. The other thing to mention about test results and normal being a statistical construct is that when we're inventing a new test and deciding how it's going to guide our decision making, there's a trade-off between sensitivity and specificity, which I'm going to talk about later. But for example, if we decide that on an exercise ECG, so on an exercise stress test, if we decide abnormal is at least 0.5 millimetre of ST depression, we would not miss any cases of coronary artery disease, but would generate a lot of false positives, which has its own problems. On the other hand, if we decided a cut-off point for abnormal is 2 millimetres of ST depression during an exercise test, we're going to pick up most cases of important coronary artery disease, but actually very few false positives. And this trade-off is calculated using something called the receiver operating characteristic curve, and that's a statistical construct. That's how we choose what's an abnormal test result and what's a normal test result. So just understand this idea of normal being a statistical construct that we've generated to help interpret tests. There are factors other than disease which influence test results. So age, creatinine is lower in old age due to relatively lower muscle mass. So you can have a significantly reduced EGFR in old age with a normal, in inverted commas, creatinine. Ethnicity, healthy people of African ancestry have lower white cell counts. Young black men can have abnormal looking ECGs, they're normal variants. Pregnancy, several tests are affected by late pregnancy. Sex, there are different reference ranges for males and females. And finally, you can get spurious results. So, for example, hemolysis causing hyperkalemia, thrombocytosis causing pseudo-hyperkalemia. Tests also have something called operating characteristics. That's to do with how the test is performed. And some conditions are paroxysmal. That means the test result may only be abnormal when the patient has symptoms or only sometimes. So half of patients with epilepsy have a normal standard EEG. This is an image of an EEG, which is like an ECG of the brain. So 50% of people with epilepsy have a normal standard EEG. But on the other hand, around 10% of patients who do not have epilepsy will have epileptiform discharges on their EEG, This is referred to as an incidental finding. And incidental findings are normal, they're quite common with increasingly sensitive tests. And it's important that all tests are interpreted in the light of the clinical history and physical examination. Now, ultrasound is an example of a test that's highly operator dependent and also depends on the patient's body habitus and their clinical state. So it's quite common to see an ultrasound result that says no abnormality detected, but if you read the report in full, the pancreas was obscured by a bowel gas, there were limited views due to the patient's body habitus, etc., etc. So that's not no abnormality detected, that's a non-diagnostic scan, and that can be very important to appreciate. A very important concept to appreciate is sensitivity and specificity. All tests have this characteristic. There's no such thing as a test that can 100% of the time detect people with a disease and 100% of the time exclude people without it. Even the best tests have, say, 90% sensitivity and specificity, and that means they'll miss 10% of people with the disease and incorrectly identify 10% of people who are normal as having the disease. So we have a very important concept of true positives and true negatives, but also false positives and false negatives, and that's really important to understand. So sensitivity is the ability to detect true positives, and specificity is the ability to detect true negatives. And the way I remember this is to think about sensitive fingertips picking things up. Now, a very sensitive test will detect most diseases, but may generate abnormal findings in healthy people. A negative result will therefore reliably exclude disease, but a positive test result is likely to require further evaluation. One example of this would be D-dimer. A very specific test can miss significant pathology, but it's likely to establish the diagnosis beyond doubt when the result's positive. Example of that might be the nasopharyngeal swab testing that we're doing for COVID-19. Now, all tests are different, and so as a clinician, you should at least have a rough idea about the characteristics of the test that you use every day in your own clinical practice. Here's a simple clinical example. Imagine an elderly woman is admitted following a fall. She's hurt her left hip and is unable to weight bear. On examination, the left hip is extremely painful to move, but her x-ray is normal. And let's imagine the x-ray is AP and lateral and reported by a musculoskeletal radiologist as showing no fracture. Now, you can Google the sensitivity of plain x-ray in the diagnosis of suspected fractured hip in the ED, and the sensitivity is 95%. That means it'll pick up 95% of hip fractures, but 5% will be missed, and that's important to know. So in a patient with a high clinical probability, so that's based on your history and examination, in a high clinical probability patient, a normal x-ray does not exclude a fracture in this case. But in a low clinical probability patient, a normal x-ray does exclude a fracture. This is a very important principle, that the probability that someone actually has a disease depends on the clinical or the pre-test probability. That's your judgment based on your knowledge of epidemiology, basic science and clinical medicine, your history and exam, plus the sensitivity and specificity of the test. And the most fundamental principle in clinical decision making is that the interpretation of new information depends on what you believed beforehand. This statement's from a book from the American College of Physicians Medical Decision Making. And because maybe it's American, they say, once you accept this principle, your life will never be the same again. Now, what they're talking about is this idea that the interpretation of new information depends on what you believe beforehand, is conditional probability, the probability that something is true given that something else is true. And that's called Bayes' theorem, or Bayesian reasoning, which I'll talk about in a second. So back to our 60-year-old smoker. Here we 90% think he's got obstructive pulmonary disease. What's the answer? Well, there are some websites where you can type in pre-test probability and sensitivity and specificity, but of course doctors don't do that in clinical practice. What we do is we make a judgment as to whether a disease is unlikely, or I'm sitting on the fence, or likely. And then we see how the test results shift our thinking, often by less than we realise. So there may be slightly different figures, but spirometry in the community is quite common. It has a sensitivity of around 95%, a specificity of 85%. And so if our starting point is that the patient is highly likely to have the disease, then you can see here that if the test result comes back negative, he's still more than 50% likely to have the disease, even with a negative test result. A positive test result has just confirmed what we already knew. But if we were sitting on the fence to start with, 50-50, you can see how the test result has really been helpful. If it's negative, he's unlikely to have the disease. If it's positive, he's likely to have the disease. And this is Bayes' theorem, Bayesian reasoning. Thomas Bayes, English clergyman in the 1700s. His mathematical formulae are used in economics as well as in medicine. And this is what doctors do all the time. And if you understand basic science, this makes sense, because emphysema is a disease of the very small distal airways, the alveoli, whereas spirometry is really measuring more proximal airways and obstruction in those. And we use it for diagnosis because it's readily available. But here you can see that emphysema, severe emphysema, can be missed just with spirometry. But actually it's picked up either on CT or on full lung function testing, which also measures something called the diffusing capacity. Full lung function tests are what are done in the hospital. So the combination of spirometry plus diffusion capacity picks up nearly all cases. So at this point you may have some questions, and one of the questions I usually get asked is, well, can we even believe a test result? The important thing to understand is that test results have to be interpreted by a trained clinician who has taken a history, examined the patient, and has a sound knowledge of epidemiology, basic science, and clinical medicine. Take a moment to jot down some thoughts and some questions that you might have for your further learning and study. Now what we're going to look at is something slightly different, and that's how the prevalence of disease in the group to which the patient belongs can affect how we interpret a test result. So take a look at this problem. If a test to detect a disease whose prevalence is 1 in 1,000 has a false positive rate of 5%, what's the chance a person found to have a positive result actually has the disease? So what I've done here is I've taken away clinical probability. You don't know anything about their symptoms and signs. Assume there are no false negatives and see if you can work out the answer to this problem. You might want to pause the video for a moment. Well, the answer to the question is that if we took 1,000 people and did this test, we'd get 50 false positives back to the lab, and we'd get the one true positive back to the lab. That's 51 positive results. But of course, only one of those is someone who truly has the disease. That's 1 out of 51, or 2%. So the answer to the question, what are the chances a person with the positive result truly has the disease? The answer is 2%. And this emphasises something very important, which is about understanding prevalence. Too often when we're talking to patients, we are swayed by the story, the history and the examination, and we neglect prevalence when making our estimate of clinical probability, and that's actually quite important. I've got an example coming up. The predictive value of a test result is a combination of sensitivity, specificity, and prevalence. So sensitivity and specificity, they're characteristics of the test. The population doesn't change this. It will be the same whether the test is performed, if it's the same test, in New Zealand or in the UK. But of course, as clinicians, we're interested in what are the chances that a person with a positive result truly has the disease. That's the positive predictive value of the test. And the predictive value of a test will vary depending on the prevalence of disease in the population. And so if a disease is quite rare, you're more likely to get false positives. If a disease is really common, you're more likely to get false negatives, that kind of thing. Here's an example of why prevalence matters. A 30-year-old woman complained of a dull left-sided headache. She's very tender over her left temple, and the trainee ACP remembered learning about temporal arteritis, so requested a blood test, ESR, a test for temporal arteritis, and it comes back very high. It's abnormal. So the ACP diagnosed temporal arteritis and started steroids. What's the problem? The problem here is that temporal arteritis doesn't exist in this age group. So the prevalence of disease in 30-year-old women is 0. And that means that even after taking a history and examining the patient, the clinical probability of this disease in this particular patient is 0. And that's the importance of understanding epidemiology when making a judgment of clinical probability. So to summarise, tests give us test probabilities, not real probabilities. Test results need to be interpreted. Tests are affected by several things: how we define normal, which is a statistical construct, factors other than disease, operating characteristics, sensitivity, specificity, prevalence of disease in the population. And don't forget this concept called the critical difference, which is this idea that lab tests can vary due to natural and lab variation by a certain percentage before they really have changed. So test results need to be interpreted in the light of the pre-test probability and also in the light of your knowledge of all of these things. And unfortunately, studies show these concepts are poorly understood by healthcare professionals because there is little systematic training in this particular area. Now again, you may have some questions. Just take a moment to jot them down for your future learning and personal study. And you need to put this into practice in in real clinical situations, working with a supervisor and an expert who can give you feedback. Now we're going to look at the third component of clinical reasoning, which is problem identification and management. We'll start with a case history again. So this is an 18-year-old man who's gone to the GP surgery. He's been seen by a very good final year medical student, and the student presents her clinical findings to the supervisor. So the patient had a 48-hour history of feeling feverish, off his food, he'd vomited once, he had central abdominal pain, he'd not opened his bowels for 2 days. On examination, he's tender in the right iliac fossa. When the medical student was asked her differential diagnosis, she said constipation. So just hold that case history in your head for a minute, and we'll just explore a little bit more about how we identify problems in clinical practice. So remember, I talked about how in everyday life and in clinical practice, pattern recognition is how we make judgments and decisions a lot of the time. And for an expert, the question, which is the cat and which is the dog, is easy and there's no thinking involved. It's widely accepted that the human brain has two systems that drive problem solving and decision making, supported by lots of experiments. We have this intuitive pattern recognizing way of thinking and decision making, and a more deliberate analytical one which involves cognitive effort and uses working memory. The two operate independently, simultaneously and always, and psychologists reckon we spend most of our time in the sort of automatic system one. With learning and experience, we can use this more. If you take a look at this picture, and tell me what it shows. Most people find this difficult. If I show you some more pictures, then at this point, some people can see the outline of a cow. And that's because once you've seen lots of different cows, many, many times, lots of different images, you don't need to see the whole thing to know what you're looking at necessarily. Now, dual process theory is now widely accepted as the model of diagnostic reasoning. When we see something that we recognize, we just pattern recognize. And if we don't recognize it, we go back to first principles using our knowledge of basic sciences, medicine, and take a systematic history and physical examination and think things through. But of course, just because you're in your intuitive mode of decision making doesn't mean you can't stop to think about your own thinking. And it's a very important quality among clinicians to be able to think about your own thinking and to be aware of your own thinking. Now, when we default into pattern recognition, in psychology, that's termed a bias. It's a normal operating characteristic of the human brain, and they're everywhere. If I see this patient with this rash, I will jump to the conclusion that this is shingles. And hopefully, if we're next to a patient on a cardiac monitor and this happens, we will leap into action immediately with very little thinking involved. These heuristics, these pattern recognition things or biases, they're shortcuts. They're neither good nor bad. And in fact, in studies of practicing clinicians, correct diagnosis is associated with spending less time on a task. However, there's a definite positive effect of reflection during decision making, and this is mainly observed when the case is more complex relative to the stage of training. So there are several studies that have been performed looking at the effect of reflection during decision making, and among learners in particular, guided reflection improves diagnostic performance. I'll explain what that means in a minute. And also immediate feedback using contrasting examples helps to improve diagnostic accuracy. So lots of evidence that stopping to pause and just ask a question that can be as simple as, what's the evidence for this diagnosis? What else could it be? But also more structured reflection could be things like listing the findings that support the diagnosis, listing the findings that go against it, listing the missing findings you'd expect to be present if this was the diagnosis. That more guided reflection, contrastive learning, contrastive feedback from a teacher is very, very helpful. And in fact, structured reflection while practicing with cases does foster the learning of clinical knowledge. But in our everyday clinical practice, when we qualify, the teacher may not be there. And this is of great interest to psychologists. Why does reflection work? Well, this is a different representation of System 1 and System 2. And psychologists have divided System 2 again into two: the sort of algorithmic mind, the deliberate, analytical thinking bit, and the reflective mind. And that's because people do vary in their natural tendency to seek information, to look for evidence, to analyse, weigh things up, to be healthily sceptical of other people's diagnoses and what the patient is reporting, to be aware of context, and to think about their own thinking. And this is clearly demonstrated in studies to be independent of knowledge and intelligence. And this is felt to be important in optimal decision making, and it's also felt to be teachable. And this is called tri-process theory because it distinguishes the reflective from the algorithmic and the intuitive or the autonomous processes that we all use when thinking and making decisions. What reflection does is it triggers System 2 being able to interrupt System 1 and to simulate alternatives. What's the evidence for this? What else could it be? Is there something missing? Do I need to find out more? Am I thinking this just because so-and-so has said it to me? Am I making shortcuts because I'm actually really hungry and this is the last patient out of a very long list of patients that I've seen? You see, humans are cognitive misers, and shortcuts have evolved to conserve cognitive energy, and they do work most of the time. But there is this very well-established distinction between our cognitive ability and our cognitive style. And one of the reasons why reflection works, especially in complex cases, it doesn't necessarily work when things are straightforward, is because it helps us to stop and ask ourselves important questions. But of course, this only really works when we have the cognitive energy to do it. And human factors is the science of the limitations of human performance. It studies how human thinking and decision making is impaired by things like fatigue, interruptions, cognitive overload, night work in particular, and also things like poor team communication. So I do encourage you to read Chapter 6, Human Factors, in the ABC of Clinical Reasoning. Many factors have been described that impair our ability to think and make good decisions, and the things like fatigue, stress, physical illness, night shift work, interruptions, and so on, they affect system 2 more, and that's when we're at risk of maybe making these cognitive and affective, that's to do with our emotions, biases, these shortcuts that can lead to error. So the summary of that section is that human thinking and decision making relies on 2 distinct types of processes known as System 1 and System 2. They're neither good nor bad. Pattern recognition is what experts do. Humans are cognitive misers. We're always seeking to conserve cognitive energy, especially under particular circumstances, such as working at night. But we do know that reflection leads to improved diagnostic performance in studies, and our ability to engage in reflection or type 2 thinking is impaired by many internal and external factors, including perhaps our personality type, but we think it's something that can be taught and something that can be learned. So if we go back to our case, the 18-year-old man, he's been feverish off food, he had central abdo pain, and now he's tender in the right lower abdomen. And when asked about the differential diagnosis, the student said constipation. Now, just to point out that the history of presenting complaint, the things that the patient reports, is usually in their own words, in layman's language, and often the exam findings we write down as we literally find them. But now we have to synthesize this in a way that's helpful. So the point of being a clinician is to gather a huge amount of data, then to synthesize it into what we think the problem is. And this is called the problem representation. And this is a concise, accurate synthesis of all the information gathered in the history and physical exam, sometimes initial test results. And it's a very key step in clinical reasoning. It consists of precise medical terms. These are also known as semantic qualifiers. Binary abstract descriptors such as sudden versus gradual, constant versus intermittent, dull versus stabbing, unilateral, bilateral, mono, poly, etc. The problem representation has to come before the differential diagnosis. And sometimes, for example, in elderly patients, the problem representation needs to be a problem list because there's more than one thing going on. But if we go back to our patient, this would be a problem representation. In summary, this is an 18-year-old man with fever, anorexia, and right iliac fossa tenderness. Now, hopefully, it's easy to make the diagnosis of appendicitis. And any finally a medical student, if you said that, would say appendicitis. Because converting the history and the physical exam and sometimes test results into a precise medical summary, what we call encapsulation using semantic qualifiers, that's precise medical language, it helps to organise and retrieve knowledge from long-term memory relevant to the case. And the main difference between strong as opposed to weak diagnosticians is in their use of semantic associations to organise their knowledge. So this use of precise language is associated with accurate resolution of complex problems, as opposed to near zero resolution for more dispersed or waffly discourses. So let me give you a good example from real life. A final year medical student went to see a patient and I asked him to make a problem list. It was an elderly woman. At the end of his history and exam and looking at the initial test results, he came up with acute confusion and raised creatinine as his problem list. So I asked him what his plan was, and he couldn't think of a plan. So we decided to reframe the problem, but this time using very precise medical language. And he came up with delirium and acute kidney injury. Can you see how that's changed? Automatically he had a plan because his prior learning was now easily accessed from long-term memory. He had a plan for delirium, he had a plan for acute kidney injury. So you need to practice this skill, synthesizing all the data from the history exam and initial test results, encapsulating it in a very short summary using very precise medical language, which will improve your diagnostic capability. Semantic competence correlates with expertise. So again, you may have questions or areas for your own learning and personal study, so pause this video to make a note of them now. So the final component of clinical reasoning is shared decision making. Just take a moment to think about what that means to you. Maybe pause the presentation to jot a few ideas down. And of course, most of the time we think of shared decision making as being with patients, with their relatives and carers, and that's very important, and it leads to better decision making. But the important thing from a clinical decision making point of view is to understand that clinical reasoning isn't something that happens solely inside the clinician's head. Clinical reasoning happens within teams. We share our reasoning with our phones, with computers. We use guidelines, clinical prediction rules, decision aids. And we use patient-centered evidence-based medicine. What that means is the best available evidence but applied to the particular patient in front of us. And the other thing that's really important in decision making is what I call optimal decision making behaviours. That means listening to others, valuing the contribution of others, involving the patient and carers in the diagnostic process, civility, clear communication, clear handovers. Back to what I was saying about patient-centred evidence-based medicine, this is quite important. Imagine a 90-year-old man with a recent GI bleed who now presents with an inferior STEMI, a heart attack. Should he be put on dual antiplatelet therapy and heparin for his heart attack? Hopefully the answer is no. And this is why we have clinicians. It's based on their knowledge of the individual patient to do our best to help them without first doing any harm. So decision making is something that doesn't happen inside our heads. It occurs within teams, and it's distributed. The final section in this presentation is what we can do to reduce errors in our clinical reasoning when we're seeing patients. So again, I have to go back to the fact that all the evidence points to the fact that sound clinical decision making is highly dependent on formal and experiential knowledge of medicines. That's epidemiology, basic sciences, and clinical medicine. And remember, when we talk about knowledge, we're not just talking about facts. We all know people who know a lot of facts who can't solve problems and make decisions. It's factual knowledge, but also conceptual knowledge, procedural knowledge, and also this very important metacognitive knowledge, which we've talked about a few times. The research evidence is very clear. Courses aimed at teaching the general thinking processes involved in clinical decision making are largely ineffective, but strategies aimed at building knowledge and understanding do lead to improvements. Now, on this note, we'll just digress briefly to talk about those teaching and learning strategies, because how can we develop excellent clinical reasoning ability? Well, firstly, any strategy that builds knowledge and understanding is absolutely key. And this is a whole different topic, but there are some learning strategies that are more effective than others. So, for example, simply reading books, highlighting, underlining, studying, isn't as effective as some other things such as retrieval practice and things like elaboration, self-explanation. If you want to know more about this, I really encourage you to read a book called Understanding How We Learn, a visual guide by Weinstein and Sumeraki, or go to the website learningscientists.org. But the other thing that's really important is purposeful practice with as many real cases as possible, in as many different contexts as possible, but with guidance and feedback. Experience alone does not necessarily lead to expertise. The other thing you need to work on is on developing organised problem-specific knowledge. I'm going to cover what that means in a second. And also focus on engaging the reflective mind. This idea of metacognitive control and awareness is very important. Just to elaborate a bit more on self-explanation, this is a way of elaborating on things and improving your learning. So there's studies where students have to self-explain. That means they have to speak out loud, justify why they think it's a particular diagnosis, why it's not another diagnosis. And this fosters the learning of clinical reasoning skills. We know that self-explanation, and there have been meta-analyses on this, outperforms explanation by the instructor because it helps the learner to integrate new knowledge with their own idiosyncratic existing knowledge. And it's the cognitive effort involved in the self-explanation that makes the learning happen. The passive listening to an explanation by an instructor is not as effective. The reason why purposeful practice in as many different contexts as possible is important is because experiments in psychology find that learners struggle to apply knowledge gained in one context to solving problems in another. So it's important to see as many different types of chest pain in as many different contexts as possible to really learn to manage that problem. And again, it's not just experience, but it's the coaching and the feedback that leads to expertise. You might be interested in this assessment of reasoning tool, which has been produced by the Society for Improving Diagnosis in Medicine. You can go to their website and download this as a PDF. You might want to ask your supervisor to use it to do regular formative assessments with you, and you can see the goals that you need to work towards. Now, I mentioned this idea of organised problem-specific knowledge, so I'll just touch on that now. Studies show that experts and other high diagnostic performers, they organise their knowledge in a qualitatively different way. They have organised problem-specific knowledge, so they identify the problem and they have essentially a decision tree in their head as to how they approach it based on evidence and good clinical practice. So in this particular study, this was on medical students, all the students performed the same in a knowledge test at the start. In other words, they all had the same levels of generic knowledge. They were then asked to diagnose a problem, and the ones who were better at diagnosis, they structured their knowledge differently. So for example, when diagnosing a case of anemia, the poor students just talked about anemia in quite a haphazard fashion. But the good students started with, what's the MCV? That's the mean cell volume. If it's low, I'll do this. If it's normal, I'll do this. If it's high, I'll do this. They had an organised, structured approach, a decision tree in their head for how to go about solving that particular clinical presentation. And structuring knowledge around these problem-specific concepts has been shown to promote your ability to use information from one problem to solve another similar problem, but in a different context. So I encourage everyone to develop this kind of organised approach to solving problems. Perhaps you need to sketch out your own decision trees based on your own reading and clinical practice. How are you going to approach a problem? In this final section, we'll just talk about how to reduce errors in clinical reasoning in our own clinical practice. And the first very basic thing to say is that you need to always perform a proper history and physical examination, because that's, as I hope you've seen, absolutely fundamental to diagnosis and clinical decision making. I'll give you a recent example. An ACP phoned me to refer a patient to hospital. A 40-year-old woman working in a factory had developed sudden right-sided posterior neck pain and incoordination of her right arm and some vertigo. When I asked what the physical examination findings were, the ACP told me that she'd examined the chest and it was clear. The ACP appeared to have no recognition of the fact that in this situation, a neurological examination was actually very important, nor perhaps did she have the knowledge that what she was describing was a possible vertebral artery dissection, in other words, a stroke, which was a medical emergency and potentially a different clinical pathway. So performing a proper history and physical exam is important, and you need to know how to do it, but you also need to have that knowledge to interpret what you're listening to and what you're finding. And if you're feeling a bit discouraged at this point, don't worry, because it does take years to build up that knowledge and experience, and it does eventually happen. That's why it's important to keep working in a team and keep having clinical conversations. The second thing to think about is to always do that problem representation before thinking about a differential diagnosis. And when you get to the differential diagnosis, think about the obvious thing that it is. You might want to think about one other alternative. There may not be one, and that's okay. And always think about this idea of ruling out worst case scenario. So in the case of pleuritic chest pain and breathlessness, we always cast our mind towards, could this be a PE? Sometimes it's obviously not. So that's how to go about differential diagnosis, but it becomes after problem representation. Develop that organised problem-specific knowledge I was telling you about, and use an evidence-based approach. Use guidelines, tools, decision aids when it's appropriate for the patient in front of you. Discuss cases all the time with an expert. Those clinical conversations are really rich learning opportunities. And always use SBAR for clinical handovers. It's a structured, concise way of handing over information so that it's safe and accurate. And I've given you a poster on how to refer to a specialist over the phone using SBAR. Well, that's the end of this session, which I hope you've found useful. I'm sure that you have many questions and areas for your own learning and further study. Please do go back to the beginning and just look at the recommended reading. Please read the chapter 1 from Davidson's and have a look at the ABC of clinical reasoning, just to consolidate some of this learning further.